Hello everyone, I'm Shweta Mishra, your host, and I welcome you all this evening to this PCOS Community Q&A session. We've gathered here today to help address some very basic questions related to menstrual cycle in women dealing with polycystic ovary syndrome on the occasion of the 1-year completion of the trial PCOS Tracker. We launched this tracker last year, and the driving force behind this is a mix of personal story, advocacy, opportunity, and motivation. And over the last year, the response on the app has been overwhelming, and it has been downloaded more than 19,000 times now by women who are either diagnosed with PCOS or who just think they may have PCOS to track their symptoms and understand their condition better. Every week, we are having nearly 400 participants join us. And this response just confirms how troubled women of all ages are with this enigmatic cluster of symptoms that is PCOS, and that they are looking for solutions. We have received quite a few questions from these women and girls using the PCOS tracker, as well as women from the larger PCOS community. And to help answer these and many other questions, we have our eminent guests and experts, Dr. Carolyn Alexander from Southern California Reproductive Center, and Dr. Aimee from Egg Whisperer Enterprises. Dr. Alexander has conducted extensive research on PCOS, specializes in the treatment of patients facing diagnosis of PCOS and infertility, and has been a dedicated physician for over 17 years now. Dr. Aimee on the panel is a Harvard-educated board-certified specialist in reproductive endocrinology and infertility. She's one of America's most renowned fertility doctors, famously known as the Egg Whisperer. Dr. Alexander, Dr. Aimee, welcome to the panel, and thanks for finding time to educate us today.
Thank you.
Thank you.
On the patient panel, we have well-known patient advocates, Ashley Levinson, Michelle Schwartz, and Lisa Rosenthal. Ashley, Lisa, Michelle, welcome to the session. Thank you for finding time to join us today. We are also joined by women from the PCOS Tracker community, as well as the larger PCOS community, who either ask their questions, participate anonymously, or just listen into the talk. Dr. Alexander, Dr. Aimee, I'll start with Michelle now. Michelle, over to you. Please ask your questions.
Great, thank you so much for having me today. I'm an epidemiologist and also, Shweta mentioned, a patient advocate. I would like to know, so I've heard that 35 to 45 is sort of the PCOS sweet spot when the menstrual cycle can kind of find its groove and tends to normal out. But my question is around perimenopause, which is also the time frame 40 to 50 when women start to experience perimenopause. So I was wondering if you could tell us, what can women with PCOS expect? What kind of symptoms might they have with perimenopause? How can they tell the difference between what is perimenopause and what is PCOS?
So we're really lucky. We have a lot of blood tests that we can now do that can guide a woman to answer that question. And I always tell people, get your levels checked. And especially so if you have PCOS. So part of an annual exam, I think, for women who have PCOS is to get your blood pressure checked, look at your lipid levels, ask your doctor if you need any other tests, for example, looking at your cardiovascular health. And then there's the test called the AMH test, anti-Müllerian hormone. And this is something that a woman who is curious about where she's at with perimenopause can do over time. And if you have PCOS, certainly you can't rely on having irregular cycles as a sign. We know the definition of menopause is basically having absence of periods over a 12-month period of time, and women with PCOS can sometimes see that. And if you're a patient of mine or Dr. Alexander's, we'll certainly tell you what we need to do to make sure you're not at higher risk of things like, for example, uterine cancer. And that's another thing, is making sure that you've had an ultrasound done on a regular enough basis. That would be my strategy that I would recommend for women who have PCOS, who are over 45, for example, who are really looking to optimize their health. But we know that women with PCOS are at higher risk, especially in the perimenopausal timeframe. I almost said peri-mazel tov timeframe. Are at higher risk of having, more complications from metabolic syndrome, right? So we got to watch out for that. So I think an easy test to do is just your AMH level, and make sure that if you are seeing a provider that's not educated on PCOS, there are really easy summary articles. You can print them out, bring them into your doctor, that show what PCOS patients are at risk for during perimenopause, and they make sure they just check all the boxes. You keep everything in a binder, keep your labs, track them over time. That way you can be your own best advocate if you have PCOS, especially around perimenopause.
Great, thank you so much.
All right, thank you, Michelle. Dr. Aimee, I'll just move on to Stephanie's question. She has sent in some questions. She's a 31-year-old woman, and she has been struggling with missing irregular and heavy and painful periods since the age of 15 now. And she was formally diagnosed with PCOS in 2018 at the age of 30, and she wants to conceive now and found out that she has tubal issues. So IVF is her only option now. And she wants to ask, why do cycles vary from month to month with PCOS, and how can I best regulate them? And what is the best way to try and figure out ovulation when the cycles are 33 to 50 days? Dr. Alexander, you can please answer this question.
Sure. I think that's a really important question. In terms of the periods, the reason the periods get further apart is ovulation occurs later in the cycle from when you started your cycle. And that's the mystery about PCOS, is that proper ovulation doesn't necessarily occur at a synchronously timed point. I think a lot that has to do with it is proper diet and exercise, as well as if you have insulin resistance or a hemoglobin A1C level that's higher, thinking about taking metformin, because sometimes metformin can help make the ovulations a little better. In terms of intimacy and timing in unprotected intercourse when you're trying to get pregnant, I tend to encourage people at least twice a week, if not 3 times a week, because the sperm can live in the fallopian tube and it can stay there longer. So if someone ovulates day 18 and they had only been trying day 10 to 13, then they would have missed their ovulation window for unprotected intercourse. But if your fallopian tubes are closed, then the only other option is in vitro fertilization, and that can be done where the eggs are grown with, the follicles are recruited with medication, and being very cognizant to avoid hyperstimulation syndrome, which I know Dr. Aimee is very, and I always work really hard to avoid that issue. And then the eggs are obtained with a thin needle through in vitro fertilization, fertilized, and can either be placed in at a frozen embryo, because with PCOS, there's evidence that an embryo that's placed fresh, there may be more high blood pressure and preeclampsia and issues with pregnancy and preterm labor than if you freeze the embryos and place them at the subsequent period or a month or 2 later when that lining got a chance to shed. But I hope that answers the questions that you asked.
All right, thank you. Thank you. Dr. Aimee, I'm kind of going to pool 2 questions here sent in by 2 different folks, but on the same lines. The person asks that she has been dealing with PCOS for 20 years now and have been trying to get pregnant, but she notices that she only gets her periods on pills, and she needs your advice on how to proceed further if she wants to get pregnant. And the other one was, how can PCOS impact IVF success? So can answer that.
Okay, cool. Well, I'll start with how can PCOS affect IVF success? And there's so many myths about PCOS. And one of them is you have a lot of eggs, they're all really bad. They've just been sitting there for a really long time and they're going to come out and they're going to be rotten. But that's actually totally not true. I consider my PCOS patients super fertile. I believe that all the eggs are going to come out good. Certainly there are some scenarios where you will learn that you might have less mature eggs than what you expected, because if, let's say, you have a follicle count of 40, you might end up with 40 eggs, but let's say 10 might be mature. And the way I frame that is, it takes 40 eggs to get the 10 mature out from that patient. So that's kind of how PCOS can affect IVF. You might get a lot of follicles, not as many mature as the eggs that you get out. And the one tip that I have for women going through IVF who have PCOS is try and balance your hormones up front. See, a nutritionist, a personal trainer, get all your hormones balanced first, because then your cycle will be optimized, and then you'll be certainly very well prepared for pregnancy. For example, make sure your vitamin D is normal, your lipids all are normal, A1C is normal, and there's so many different ways of doing that, and there isn't a one-size-fits-all approach. And I'm not a BMI calculator, and I don't pressure women to reach a certain BMI before they start. I use the hormone levels and make sure that they're balanced, and use that as you know, the green light for me to say you're ready for IVF. And then the other question about, you know, not getting a period unless you're on pills to induce one and still wanting to get pregnant. Well, if you're okay using pills like Femara, for example, Femara is an ovulation induction drug that can stimulate the release of one egg, and hopefully it's just one. Sometimes it can be more than one, but that's a strategy that we use. You've heard of drugs like Femara, Clomid. Those are 2 medications that we can use to help women who have PCOS ovulate, and they're usually very well tolerated, have a low side effect profile, but I do recommend that you do that with the help of a doctor who can also monitor your ovaries and look at your follicles and give you the information you need, like how many eggs are you ovulating, when are you going to ovulate, and is this really working for you? Because sometimes these medications at the dose that you start off with don't always work if you have PCOS the first time.
Mm-hmm. Okay, thank you for that answer, Dr. Aimee. Dr. Alexander, the next one is for you. The patient says, I was diagnosed at 14 years of age and I recovered from PCOS after treatment with medicines. I feel like my disease is back again because I've been trying to conceive for the last 18 months now. Could you please suggest what to do?
Sure.
So, Dr. Alexander, it would be great if you can, you know, comment on how do we medically decide for a patient that PCOS has been treated?
Yeah, I think like Dr. Aimee mentioned, once the metabolic function is better with PCOS, and that does tend to happen as we get older, closer to perimenopause, there tends to be more regular cycles, and some women have a pregnancy that can occur after they had been struggling for years, and that you'll hear that at 40 someone got pregnant and they had been trying for so long, and that can be because suddenly the system ovulates at a better timing. In terms of this situation where you've been trying for 18 months, it's really important to get an ultrasound to see if you've really been ovulating, and a luteal phase progesterone level to see if the progesterone rose in the luteal phase, which is after ovulation, to see if the actual ovulation's been happening, because sometimes we have been trying, but perhaps the egg isn't actually popping out to ovulate, and that can be the reason you haven't conceived. It can be remedied with Femara or Clomid, which are tablets that you take day 3 to 7 of your cycle, depending on what your doctor recommends, and that can optimize ovulation. It can sometimes cause 2 eggs to ovulate, but traditionally it usually helps us ovulate 1 egg. In addition, if it's been that long, it's important to talk to your doctor about checking a semen analysis, because about 1/3 of the time, even though we think it's us with PCOS and it's not ovulating and those kinds of things, but you're surprised to find out that it actually could be a sperm issue too. And so it's important to check a semen analysis. And then like the fallopian tube test, which is called the HSG or hysterosalpingogram, can be encouraged too, because it also potentially can flush the tubes. So theoretically, it could actually help mucus and everything clear. And so that occasionally can also be therapeutic to help the sperm and egg combine and make a pregnancy successfully. And it's important to check that your thyroid's at a normal level, your prolactin, that you don't need a medicine to lower those hormone levels if they're off kilter, and that your vitamin D level is normal. So sorry about that. Can you hear me? Yeah. Yeah, those are my thoughts.
Okay, all right, thank you for that answer, Dr. Alexander. At this point, I would like to invite Deborah Baum. You want to ask your question, Deborah? You want to unmute yourself and ask your question?
Hello.
Hi, Deborah.
Hi, how are you?
I'm good. How are you? Please ask your
Good,
question.
thank you. I'm sorry.
Go ahead, ask your questions. You wanted to ask a question to Dr. Aimee?
Yes. So my question was, can birth control help treat PCOS? And should all women take it? And what are the side effects if they do?
Great question, Deborah. I mean, I use birth control pills a lot for a number of reasons. I call them fertility planning pills. I tell women when you take it, especially if you're trying to get pregnant, I don't want you to think that I'm trying to prevent pregnancy for you. I'm just trying to put a pause on things so I can manage your symptoms of PCOS. And as soon as everything is under control, then we can stop the birth control pills and move forward with our plan. So that's one way that I use them, as fertility planning pills. And I wish that the birth control pill company out there would hear this and then maybe formulate a new pack, with a different name. You know how sometimes you have drugs like Wellbutrin and Zyban, they're the exact same drug, but they're used for totally different things, because it's so confusing for women sometimes with PCOS, especially when you're trying to get pregnant, to be told that they should take a birth control pill. And it's like, wait, am I in the right place? Am I with the right doctor? Why are you doing this? So birth control pills can also help lower testosterone levels, and depending on what a woman's goals are and how high her testosterone levels, sometimes I use it and I monitor levels. I've said this before, get your levels checked. I check a baseline testosterone, put you on birth control pills if that's, acceptable for you to take. And then maybe a month later or 2 months later, we see where your testosterone levels are, and then we decide if we should maybe stop them and see if at this point you might start having regular and more, quote unquote, normal cycles. The other thing about birth control pills I'm very sensitive about is how they change our brain chemistry. Some women are very sensitive to how they change our brain chemistry, and they become depressed on birth control pills. So if I have a patient who has PCOS and already is dealing with some symptoms of depression, I definitely don't want her to take birth control pills, but it can help manage cycles. It can decrease testosterone, and with that comes less hirsutism, that hair growth that some women might get, and acne as well. Can be a treatment. Not all women should take it. There certainly are so many other options that you can look into, but it is a tool in our toolbox that we use for patients with PCOS.
Right.
Okay, thank you.
You're welcome.
I'll move on to Ashley now. Ashley, could you please introduce yourself briefly and go on to ask your questions?
Yes, hi everybody. Ashley Levinson. Most of you know me on social media as PCOS Girl. I have been a PCOS patient advocate and educator for over 21 years now, and I'm thrilled to be here. Dr. Aimee, I have a question for you first. If only 20% of women present with cystic ovaries, is using a diagnostic tool like ultrasound a good tool to use?
My answer is yes. I find the pelvic exam, for example, to be extremely barbaric, right? So we don't have cameras at the end of our fingers, and yet sometimes women go in for their pelvic their pap smears, and they go through a pelvic exam and then find out years later that they have other pathology like a fibroid that's been growing there this whole time. And the thing is, you probably know this as much as I do, sometimes women are given this diagnosis of PCOS just based on their physical appearance. You go into the doctor, maybe you're just a little bit curvier, you report irregular cycles, they just label as PCOS, send you on your way, and then no ultrasound. But the reality is, if they had done a little bit more digging, they would have done an ultrasound, and if they didn't see polycystic ovaries and they saw a low egg count, you might be dealing with a condition called decreased ovarian reserve. And it's heartbreaking for me when people are incorrectly diagnosed with PCOS and they really have decreased ovarian reserve. And by the time they get to me, sometimes it can be too late. So that's one very important reason to look. And the other is to look at the lining. Look at the uterus and see if the lining is thickened, especially if you're having irregular cycles. So I think those are very important reasons to still do an ultrasound. But I don't rely on the ultrasound as, how to make the diagnosis, but it's definitely part of the full clinical picture and something that women should ask. Ultrasound, please.
Thank you.
Sure.
Dr. Alexander, if a woman or girl has a prolonged history of irregular menstrual cycles, how likely is it that it could be PCOS?
I always think of it, other than PCOS, as 4 issues. It still can be a prolactin issue, which is from the pituitary gland, a thyroid issue, and like Dr. Aimee said, it can be a low egg reserve. So if the FSH starts to creep up, which implies that the egg supply is lower, that can also be a culprit too. And as well as metabolic issues such as insulin resistance and not be PCOS. But at the same time, whenever there's irregular periods, our mind always thinks of polycystic ovary syndrome as an issue. So I think it's a really good question, but it's important to check all the other hormones that could be in the causal factor. As well as in LA, we see every month there's at least a couple of patients who are told, yeah, you have PCOS. And then lo and behold, they actually have non-classical adrenal hyperplasia. And that's, to me, a very different situation, because there are times where a baby can be born with ambiguous genitalia if the partner also carries a classical adrenal hyperplasia gene. And so that can be very alarming, and we see that every once in a while. And so here we're very careful to check a 17-hydroxyprogesterone to make sure it is PCOS and not necessarily a non-classical or adrenal hyperplasia kind of an issue.
And the second part of the question is, if a person with PCOS goes for a long period of time without the period, does that put them at risk for other conditions or more serious consequences?
I think, in younger PCOS patients, we do sometimes catch precancer inside the uterus, which is like hyperplasia, and it can have atypia, like atypical cells in there, and very rare, but it's happened in these 15 years that I've been doing this here, is that sometimes we'll catch real adenocarcinoma or cancer inside. And that tends to happen in people who say years and years of no period, and they didn't take progesterone to shed the lining or a birth control pill necessarily. So it is a vital sign. I call it the 5th vital sign that we should be getting our periods. Obviously, if someone has a Mirena IUD, they're not going to get their period, or if they're taking continuous birth control pills because they have really bad cramps and they need to be on birth control pills for that kind of regulation, you're not going to get your period. But taking no birth control and no progesterone and not getting your period is not really advisable, and it's good to get a checkup with your doctor and talk it out.
Thank you.
Thank you, Ashley. Now I guess I will ask Hanma's question. She was supposed to join the call, but due to so Hamna is a student and she's studying business and has a very hectic schedule through the day and very less free time. And for her peace of mind, she writes poems and short stories. And she is only 16 years old and was diagnosed with PCOS almost a year back. And she says that I'm tired of all the treatments I have to go through. Whenever I start my heavy routine, I get tired within a month. She wants to know why does this happen. And she says I've started cycling and exercising since the last 3 weeks, and I've been doing yoga, on and off, and still there are no results I see. Will I ever be cured? That's the question, Dr. Alexandra, you can answer.
Sure. I think it's a really good question. I know it's super frustrating. At Cedars, we did a lot of research to understand why PCOS even happens, and it wasn't one gene that you carry that's like a yes, no. It's from both our parents, and there are certain genes that just turn on or off from environmental things or nutritional changes, those things. So you have a little bit of control of your system, like you're doing with the yoga and cycling and eating a clean diet. Because you're only 16, so I always think of these, when we're younger, you have to have a day that you can be free on your nutrition and be normal with your friends, but the other rest of the days of the week, we should be more consistent with frequent small meals and avoiding white carbohydrates and those kinds of things. In terms of cure, I definitely have seen that after having a healthy baby, there's people who call and say, oh my God, you did tell me that might happen, but my period's back to normal and I'm regular again, and the hair is kind of a little better. And so we do sometimes see that nature after a pregnancy kind of like clears the system, but I don't have, there's no perfect cure like you're saying. I think it's just accept what our circumstances are. It's very empowering now that women know what they have, because in the past, for me, I was always overweight since I was 16, and people just said, oh, it's just you're overeating. And I actually wasn't eating badly. I was actually eating healthy, but it's just interesting to think we were just blamed that, yeah, you're just overweight because of whatever you're doing. But it was really my metabolic function that I didn't have an understanding of it till now, kind of a thing. But anyway, those are my thoughts.
Right, thank you. The other question that she has, I guess, Dr. Aimee, you can take, is on the psychological side of PCOS. She says, people keep asking me about my acne, weight gain, and I'm tired of these questions, and my mind keeps repeating these questions deep inside. I'm hurt. What to do?
Well, I mean, along the lines of what Dr. Alexander just said, it comes from our parents. So if you're 16 years old, you would just tell them, can you ask my mom? So that's one way of dealing with it. The second way of dealing with it, you just turn it back around at them and be like, isn't that funny that you think that that's an okay question to ask me? Or you just say, look, if I was a boy, would you be asking me the same thing? I don't see people asking my brother this or boys this. That's kind of rude. So I feel like you should stand up for yourself and turn it around and be like, God, how would you feel if someone kept asking you that? I don't think it would feel really good. So that's kind of what I would equip you at 16 with, to like turn it around and just try and make it something funny. And if they persist, literally tell your mother and have your mother call them and tell them to stop, especially if they're adults, because they should know better.
That's right. Thank you. That's a great tip, Dr. Aimee. I guess now I'll move on to Lisa. Lisa, please go ahead. Please introduce yourself a bit and then go ahead and ask your questions.
I am thrilled to be here getting all this incredible good information. My name is Lisa Rosenthal, and I'm patient advocate at Reproductive Medicine Associates of Connecticut and have been here for 12 years. I've been an advocate for 30 years and went through 6.5 years of infertility myself with, guess what, undiagnosed PCOS, right? Never diagnosed. Went to some of the top clinics. I had a little bit of this, a little bit of that. It was a long time ago, obviously, but as one of the leading causes of infertility, PCOS is always, of course, on my radar. So thank you for having me. So Dr. Aimee, one of the questions I got when I asked some of our patients was, I'm determined to manage my insulin resistance with diet and exercise. Is this really possible with PCOS, or do I have to be on medication?
So you know all too well that so many women go years, decades of their life before they get a diagnosis. And they're sometimes given a diagnosis at, let's say, 20, and then they're told, well, you don't really need to worry about it until you're ready to have a baby. And by then, testosterone's through the roof. And now you're dealing with something that's going to take longer to manage. And so it really kind of depends where you're at, you know, what's going on with your hormone levels. I have patients that, you know, they meet me and they're like ready to go. Like they want a jump start. And so I do find that giving them some tools like birth control pills, spironolactone, metformin, I call it my PCOS, special sauce, so to speak, of supplements. And you don't necessarily have to try all of them at once. You can try one set first, see how you do. Try another, just kind of see how your body reacts. But I think that patients who have high testosterone, it affects your mood, it affects your appetite, it affects your metabolism. And you might not see the same results that you would if you maybe tried a whiff of metformin, for example, and then continue to do all the right things that you're definitely doing. So that's what I tell my patients, is that you don't necessarily have to be on medication. We can certainly, focus on eating right, or, meeting with a nutritionist, for example, but sometimes just that little boost of drugs can sometimes help you see the results quickly, and then you'll feel very encouraged, because it's very discouraging not to see the results that you want. I hear it all the time. So that's kind of how I guide my patients on this question.
Okay. Thank you for the answer. If I were going to follow that up, I would ask about, so many patients seem to have a lot of trouble with metformin, but I'll go on to my next question. So Dr.
Sure.
Alexander, nice to see you and meet you. How genetic is PCOS? Let's say I have daughters. Is there something I can do while I'm pregnant and as soon as she's born to help her avoid PCOS? Are there genetic markers? Can pre-genetic testing help me pick an embryo that won't have as high a likelihood for PCOS? I know it's a big question, and
that's a good question. Well, it is when we did do like the cross analysis of all the different genes, it was associated with, there were like 20 or more that were hot spots of genes. So there isn't a pre-implantation genetic diagnosis, One thing I've noticed over the years is that there is a high family predisposition of diabetes. So a lot of the family history will have diabetes in the family. So grandma or grandpa or the aunt has diabetes. And so I think in teaching our kids proper, what to crave, like cucumbers and celery and those kinds of things versus candy and chips and things like that. So I think there's a little bit of that there. The pediatric population does look at early breast development and early underarm hair as like a smoke signal that maybe that might be one of the clues that there's a higher level of hormones popping up in a younger age. I think that's an opportunity to talk to those girls with the nutritionist and work as a multidisciplinary approach to her. And I think, it's under-recognized, but like the psychological aspect that maybe there might be a hormonal imbalance that, you may have. They've done epigenetic changes in pregnancy in some women who really don't eat very much food, that those kids get genes that turn on that may cause more PCOS, but it's hard to blame. I don't like looking back and trying to blame our mom or whatever it is, kind of a thing. But I think there isn't anything specific of a genetic mutation that we know of, but I think there's clues that we can get. And if we have a family history of diabetes, it's important to think about it for our girls and the boys too, because they can have metabolic syndrome. There was some long-term studies that we had done looking at the boys of moms with PCOS, and they also sometimes have a propensity for obesity and metabolic syndrome as they age. So it's important to empower them too. But that's my thoughts.
Well, thank you. That I know it was a lot, and it of course speaks to the fact that we need more money for more research and all of that. So also for Dr. Alexander, one of the things that I hear from patients all the time is, how could I be on birth control when I'm trying to get pregnant? So the question from this one patient was, I've been diagnosed with with PCOS and I'm on birth control, but what's going to happen when I want to get pregnant? I'll have to be off birth control, and I'm afraid of how bad the symptoms of PCOS will be.
Yeah, I think that's a really good question. I always get asked, like, when is the perfect time to stop the pill when I'm thinking to try, let's say in December and we're in the summer? I tend to say, like Dr. Aimee mentioned, is like your testosterone and your metabolic tests are normal, right, in that 6 weeks after we stop the pill. So you really want to give it a full try to get pregnant once you stop birth control pills. There isn't this, it might be an old thought that we used to do, is say take 3 months off the pill and then start trying. No, now we kind of, at least from my side of it, I always say start trying right away when you stop the pill, because it seems that people stop the pill and get pregnant pretty easily. And that's what happened with me. But I was really worried because I was in my late 30s and I thought, oh no, I'm going to have infertility because I'm a fertility doctor. And then it just sort of, I planned it out with the metformin timing, and I had stopped spironolactone 6 weeks in advance because it's not allowed in pregnancy. So we try to stop it a little bit more in advance, but at least it helps regulate your hormones. But I definitely understand how challenging that is, and frustrating when you're on the pill, but you want to be pregnant. So.
Thank you again. Very thoughtful, very informative answers.
Right. Thank you, Lisa. Thank you, Dr. Alexander. I guess I'll move on to some questions sent in by the PCOS Tracker and, from the larger community. This one is for you, Dr. Aimee. The person says, I've had irregular periods for the last 5 years, and periods getting delayed by more than 3 to 4 weeks. And I really have good amount of pain when they do come. So what do I do? What can you suggest?
I mean, I think the most important thing is to see a doctor, get an ultrasound done, take a look at your uterus, see if there's a fibroid, see if there's endometriosis. I mean, you can have PCOS, endometriosis, and fibroids. So I think that's really important. As far as what to do about the pain, I mean, I think that, identifying the cause, and then, you can actually treat the pain with, birth control pills is one way to do it in someone who's not trying to get pregnant, because that can decrease the amount of menstrual flow. If there's endometriosis, it can prevent the progression of endometriosis as well. And then, you know, get your hormone levels checked, like your testosterone and all the things that we've talked about, like AMH as well. And then the other thing that might help is, you know, looking at your body size and how you're eating. That might be something to focus on as well, because if, let's say, you lose, let's say, 10% of your body weight, there is a potential for having less menstrual pain with your periods when they come, and that might help regulate your periods as well. So those are the kinds of things that I would think of in a case like this.
Right, thank you. Thanks. Thanks for the great answer. And the next questions, yeah, those are mostly on the lines of, you know, diet and weight related to intermittent fasting, basically. And the person is asking, Dr. Aimee, Dr. Alexander, both of you can chime in here. Can I lose weight on PCOS? And the person says she lost her periods when she was intermittently fasting, and then went on a 1200 calorie diet. And I was nearly underweight then. Now I have gained back all the weight and plus more. So with regular periods, but I am too chubby, and, you know, I want to lose weight. Is it possible with intermittent fasting? That's what she asks.
Dr. Alexander, what do you think about intermittent fasting? Are you a fan?
I know I get hesitant about it just because I feel like the hypothalamus pituitary ovarian axis thinks it's in starvation mode, but I know from certain body types that 8 p.m. to 7 a.m. or 8 p.m. to 8 a.m. is like the best time to like not really eat anything, maybe decaf green tea if you really need something. But that I've seen people say like that they had a dramatic improvement. But the whole like people who say 16 hours through their whole day they ate nothing and then randomly like wolf down all this food, I'm not sure. But so I'm not an expert on it, but I'm not sure about it because I don't know if I could really do that. So.
I mean, I think it might be worth trying to see if it works for you, but becoming overly hungry just doesn't sound like any fun to me. The term I would think of immediately is called hangry, when you're hungry and angry, and then all of a sudden you just make maybe some poor choices with food, you know, options that you have. So I'm not a big fan of intermittent fasting in my patients, but I totally agree with what Dr. Alexander just said.
Okay, the next question asks how to lose belly fat with PCOS. I was diagnosed in 2018 and lost weight after that, got regular periods for 2 years. Recently, since April, they are back to irregular again. I eat good and work out regularly. What do I do? So basically, it's about belly fat and PCOS.
The belly fat, yeah. I mean, even though maybe medication's not always the answer, but in my experience, if they take the metformin, even 1 tablet a day, I've seen people with, especially the tummy roll that's above your belly button. I've seen a lot of people, and it may be a mental fat pad, but the metformin seems to help. There's some evidence about myo-inositol too, which is non-medication. It's like a supplement, but I think it's for me, I've seen that the metformin helps. I obviously exercise is critical, but it sounds like the person's exercising already. And I always believe people when they say like I'm exercising so much in calorie restriction, but my tummy and the bloating, sometimes it can be an underlying thyroid issue too, or probiotics can help. But we've learned now with newer studies about probiotics that not taking a probiotic every single day is actually better. So taking it like twice a week or 3 times a week may be more realistic for the GI tract than to do everyday probiotics.
Okay, thank you, Dr. Alexander, for that answer. The other one is about bloating and PCOS, and I think I've got quite a few questions and I've pulled it all together about this. And the person asked, will PCOS cause bloating? I get a lot and it hurts. How can I avoid bloating too much? Should milk be avoided? Dr. Aimee, if you want to take it.
I mean, what I would say is I have patients that they feel like they're getting their period all the time, but it doesn't come. And I think sometimes as your lining thickens, your uterus swells and contracts and you can feel cramps and it can feel like a form of bloating. So certainly trying to regulate your period and focusing on that can sometimes help with that bloating. And then it could also be something else. So, you know, there are so many other things that can cause bloating, not just PCOS. So it would be important to also see a specialist to make sure we're not missing another diagnosis.
Okay, thank you. The other question is, okay, so that's a far-fetched question. I guess everybody's trying to find an answer for that, but the person is asking, can you suggest how to cure my PCOS? So actually, Dr. Aimee, Dr. Alexander, what does research say so far? How far are we in finding a cure based on, you know, whatever we have seen in these recent years in research?
Carolyn, you want to answer that?
Sure, yeah. I think I wish, you know, there's no magic cure. It's a chronic LH elevation from your pituitary that starts before puberty. So like even before we start to get breast development and underarm hair, there's this chronic LH elevation that's just beating on the system that makes the ovaries evolve in its pathophysiology and the way the functioning of the ovary is. I think the challenge is that it's not like we can catch that before it starts to happen. I think early intervention is just recognizing the symptoms in early puberty. I think the other like flip side is there are some people who pop up with just really bad insulin resistance, but they're having regular periods. So I think it's a really mixed group of women, and there isn't necessarily one big cure. I wish there was, but I just can't think of it. I think that the important thing is just protecting yourself and keeping track that your uterus is protected from precancer, you're protected from type 2 diabetes by exercise, diet, and in potentially, if needed, a medicine. And when you're trying to get pregnant, talk to a doctor like one of us or whoever, your OBGYN, and then empower yourself with the information.
Yeah.
Thanks. Ashley, you wanted to ask a follow-up question? Can you unmute yourself, please?
Yes, please. I'm interested to find out from your perspectives from both of you. Is insulin always a factor with PCOS? I have some women and girls who say, I'm not insulin resistant, but then I hear that there's always some sort of issue with insulin, whether you're insulin resistant or not. So does that play a factor? And is that something that we should be looking at more with PCOS with diagnosis and treatment?
Yeah, I mean, from my standpoint, it is like when I was trained, we checked fasting insulins on everybody, no matter what your body size was. So it is part of my diagnostic tool set, you know, that I do for patients. And it's not something that I see elevated in everybody, but it can also help me guide treatment. And I use it as a benchmark, you know, check it in the beginning and then follow up and make sure that it has come down before we initiate treatment to help someone get pregnant, for example. So that's how I would answer that.
And it seems that in Los Angeles, the thin PCOS patients are the ones who call me and say they got gestational diabetes in pregnancy. And I always find that interesting because their hemoglobin A1C and their insulins are normal, but it's the thin PCOS patients that I tend to see this like anecdotal clinical thing where they have a higher propensity for gestational diabetes in pregnancy. So I don't know if, and then that has a ramification for lifelong increased risk of type 2 diabetes when you get older. So I think is probably some underlying interesting phenomenon of insulin, but we just can't always detect it.
Mm-hmm.
Thank you.
All right. Lisa, you have a question. Can you unmute yourself, please?
Yeah, sort of relating to a PCOS cure, could you explain why it's called a syndrome and not a disease? A lot of people, you say disease and then it's sort of corrected, but what makes this a syndrome rather than a disease?
I mean, the way I think about it is because there's so many symptoms associated with it, and not everyone has all the symptoms, and so that's why I think of it as a syndrome. And you know, maybe if we thought about it as a disease, people would get early diagnosis and treatment from a young age and see a specialist, rather than, you know, syndrome sounds like kind of soft, and there's so many different things that are involved, and sometimes that can be a little bit confusing for people. That's why I think it's called syndrome.
Yeah, I agree.
Is there any possibility that PCOS is sort of this big umbrella diagnosis, or is it really just as complex, complicated, and multifaceted as it seems to be?
I think it is exactly as it seems to be. There's no, it isn't the same thing for every single person. And, you know, for some people, it could mean having a really hard time getting pregnant and not responding to fertility pills. For other people, it could mean just a whiff of fertility pills and they get pregnant every single time. So, you know, that's why everyone should be treated like an individual. And I actually have renamed PCOS. And I'll tell you, I've renamed it HOPE syndrome. The H, you know, this is just a very simple way for people to know exactly what it means. So the H is high androgens or high testosterone. The O is lots of follicles on the ovaries, okay? The P is irregular periods, and the E is eating and exercise, right? So that's what makes it HOPE syndrome. And it's not about being infertile or having rotten eggs or having a hard time getting pregnant. It's literally about these things. And if you know what it is from the very beginning, then you address each of those things, and then voila, you're not seeing me at the age of 40 finding out that you have the diagnosis for the first time.
Dr. Aimee, I must tell everybody that you are fabulous at making abbreviations of things.
Yes.
I love that. That's wonderful.
And then I saw some fertility plans on your website. I mean, those are just, I mean, who could have thought of that?
Yeah.
So thank you for that. Thank you.
Sure.
I guess, yeah, the other question that just came on Instagram is, how do I know if I have adrenal type PCOS? Dr. Alexander, you want to take it?
Sure. Yeah. I see a lot of Asian women having very high DHEAS, and they'll sometimes get cystic acne on their back. And when we were looking at the, like the genetics of all this, it was interesting because in different ethnic groups, there were different genes that turned on. But the adrenal type of PCOS is a little interesting because birth control pills doesn't lower that male hormone. So some of the patients will say their mood and the feeling that they just feel hormonally off, it still stays even when they've taken birth control pills, which is supposed to lower the internal testosterone level. So adrenal PCOS can be kind of from the DHEAS being high, but that's different than adrenal hyperplasia, which I don't know if that's the question, but congenital adrenal hyperplasia is a genetic specific mutation, and that is a high 17-hydroxyprogesterone, and that's important to do when you're not on birth control pills during the first week of your period. And if that level is over 200, that can be a warning signal that it's not actually really even PCOS, and that's a different ballgame.
Okay. I see Cam has posted one question here, and she asked, how do you get tested for PCOS? Dr. Aimee?
Yeah, sure. I mean, if you think of my HOPE syndrome, I mean, that's basically how you check your testosterone levels, get your ovaries checked, get an AMH level done, talk to a doctor, and the diagnosis is not that mysterious, and it shouldn't be. And so if someone is not able to give you a clear diagnosis, it's really a good idea to get a second opinion. There are good medical endocrinologists in our area that do pride themselves in being PCOS experts as well. So if you're not getting the help from an OBGYN, and sometimes, unfortunately, reproductive endocrinologists, not Dr. Alexander and I, sometimes they say things like, well, we won't really help you unless you're trying to get pregnant. And I do PCOS management for people who are not interested in getting pregnant in my practice. So if you're not getting the help that you need, you know, reach out to one of us, either Dr. Alexander or I, and we'll guide you to find someone that can help you.
Sure, thank you. So what age is a minimum age to get tested for PCOS, Dr. Alexander?
There isn't any specific age. I think I work closely with our pediatric group near us, but typically it pops up around 16. But I think if younger girls are having issues, it's important to talk to your doctor. I'm very hesitant to start young girls on birth control pills, so I'm very more natural for them till they get a little bit older, unless they need contraception, which is a different discussion. But there's not a specific age to diagnose it. It's just a discussion.
Okay, All right, thank you. I guess another last question, a couple of last questions. Is it safe to take metformin and spironolactone to treat PCOS? I've heard spironolactone could cause harmful birth defects. Dr. Aimee, you want to?
I mean, I love spironolactone. I think it's a great tool. I take it myself, hence the clear skin right now. And if I don't take it for like 2 weeks, all of a sudden my cystic acne comes back and I get really annoyed that I didn't refill my prescription. And so, my style is, there's a certain amount of time for patients who are trying to get pregnant that I have them on it, and then I have them stop it, for example, when they start their ovulation induction medications or when they start cycling to try and get pregnant. So it is safe to take with metformin. However, if you're trying to get pregnant, obviously we don't recommend it and we don't want you to take it if you're trying.
Ashley, you have any final questions? Can you please unmute?
Yes, I do have one final question. Lifestyle management is often brought up that's really kind of the pinnacle as far as PCOS treatment. So what can we do to live a healthier lifestyle with PCOS? What steps should we be taking?
I'll start. I'm very passionate about this, and I feel like you need a team. And believe it or not, I have a mnemonic for that. I mean, it really is, like Dr. Alexander said, multidisciplinary approach. And you can't take someone who's been living with this for 40 years and just say, go find a trainer and find a nutritionist. It's not as easy as that. I mean, I do think involving a therapist, a physical trainer, definitely. So team is therapy, eating exercise recommendations, acupuncture even can help. Believe it or not, I've had some great results with acupuncture with my PCOS patients, especially those who are not responding to fertility drugs. I've seen them help my patients with their, magic that they do for me. And the last thing is meditation and mindfulness. So I think that you, especially now in this pandemic, you have to create your own mind-body team and create your own mind-body center in your home and figure out all those things that you need so that you can keep moving, eat right, and you're really getting the very best advice for yourself. And if you don't like the advice you're getting, like find someone else, find a group, go to your social media pages, Lisa's social media pages, and, try and build a group of people that are in the same boat as you are. And so you can all give each other really great advice.
Thank you. So that's also one of the keys. Support is so vital right now, especially people don't feel like they're getting the same care as they normally would because we're in the middle of the pandemic, and especially with the mental health aspect with PCOS, with the anxiety and the depression being so prevalent. I think it's so important that people are able to connect online and find support. So thank you so much for everything and for doing this. And Dr. Alexander, thank you as well.
All right. Lisa, would you like to ask some final questions? Or
let's see, final question. Well, Ashley really posed a beautiful question. I think, do I have a final question? I guess, endocrinologists don't necessarily want to be handling this. Pediatricians aren't necessarily handling this. That's what we've found on the East Coast. And reproductive endocrinologists don't necessarily want to be handling this. So I guess piggybacking on what you just said, Dr. Aimee, how do you find somebody aside, and certainly coming to Ashley, or she does amazing work, so I think we put out some good information too. But how do you find somebody who's really qualified so that you're not wasting your time? Because right now it's not easy to see doctors. It's easy to do telehealth, but that's my question. How do you find somebody who's really good and that you can trust?
So there is an app, it's Polly, Pollie, and I'm sure you guys know about it. So that's a telemedicine platform, I believe, that will match you with someone that will suit your needs related to PCOS. So that's one way of doing it. So everyone that is on that app is basically a PCOS expert in whatever field that they are in. And there are doctors on there that can help patients who are not getting the help that they need. And so I think that's one way of doing it. And, our country is so large, and I think, sometimes people are afraid to care outside of their state, but getting a second opinion consult through a telemedicine platform, I think, is definitely suitable. And there are enough PCOS experts out there that I think that women can get the help that they need right now. And if, like I said, and if you aren't able to find that person, I know who those people are, and I can help connect.
Right.
Thank you. Thank you.
All right, thank you so much, everybody. I think we answered quite a lot of questions, and Dr. Alexander dropped. I'm hoping she will join back again, but I'll conclude the talk now. We are already at the end of the hour. So folks, we were listening to Dr. Aimee and Dr. Alexander answer questions related to everyday lives of women dealing with PCOS. We heard the panel guide us through some very basic questions and help us understand how we can deal with PCOS better. We hope we were able to touch upon quite a few of the many doubts that we women dealing with PCOS have, and hope that the discussion was helpful to those who are newly diagnosed as well. Dr. Alexander, Dr. Aimee, thank you very much for your time and all the information that you shared with us today. Michelle, Stephanie, Ashley, Lisa, Deborah, and Lorraine, thank you for joining the panel, and each one of you in the audience, thanks for your participation and your insightful questions that brought out a very informative discussion today. I request everyone to check out the PCOS Tracker that has now been downloaded more than 19,000 times, and I would appreciate each and every feedback on that. That will help us make the tracker more helpful for women, as well as help advance PCOS research. So we are looking to collaborate with research teams working on PCOS or women's health, so that we can put the anonymous contributions that we have on our app from citizen scientists to some constructive use to help PCOS research. So if anyone is interested, please write to me at shweta@trialex.com, and this talk will be available on qtalks.com soon, and the link will be shared with everyone. So please visit our website for details on upcoming talks. Until next time we meet, wish you all well. Thank you and have a great day. Stay safe, everyone.